So, Marta Siepsiak is a psychologist, cognitive behavioral psychotherapist, and music therapist. She is an assistant professor at the Faculty of Psychology at SWPS University in Warsaw. For almost 9 years, her research has focused on misophonia in children and adults, examining its links to psychopathology, audiology, psychophysiology, and cognitive processes. She currently leads a research project funded by the Misophonia Research Fund, investigating the mechanisms and efficacy of psychological interventions for individuals with misophonia. She has previously conducted research as a principal investigator under grants from the Polish National Science Center and was a visiting researcher at Duke University and the University of Barcelona. In addition to her academic work, she is also a clinician working with children, adults, and families, particularly in the areas of anxiety disorders, OCD, sensory sensitivities, and neurodevelopmental conditions. Now I will give it off to Dr. Siepsiak.
Hello, I'm Marta Siepsiak. Thank you for the introduction and thank you for the possibility to be here. I'm so happy. Yes, so I am a researcher, psychotherapist, psychologist, and I have misophonia myself. So I was also a child with misophonia. Apart from my research, I love working with students. There are in the lab before, like in training, and I also work in private practice with children and adults as well, mostly, but not only with misophonia. And this is our lovely team that we work on that study together. And our main goal was to describe clinical characteristics of children with misophonia. And for that, we met a part of our participants at the Faculty of Psychology, University of Warsaw in person, but due to some time constraints, we had very little time, and we traveled across Poland visiting children and the parents in their homes. So I'm really grateful that they allowed us to do so. And we published 2 papers, but I will also share some data that is not published yet, like very preliminary data. We had 2 groups, misophonia and controls, without any sound issues. There were no age differences between the groups, but please note that in misophonia group they were slightly older, and that can change in this developmental group. And about the study structure. First, we contacted usually mothers, sometimes fathers as well, by phone. We asked about the misophonia symptoms. We included only children who were triggered primarily by eating sounds, but I would like to stress out that I'm not saying that only eating sounds can be misophonic triggers, not at all. That was just our inclusion criteria for some methodological reason. And then when we finally met them in person, we asked lots of questions about symptoms of other disorders, about coping strategies. There were lots of questionnaires. We also asked mothers about their mental health. We had performance-based tests about memory, attention, intelligence, and then also hearing tests and auditory processing tests. So lots of testing. And then half of our participants had their misophonia symptoms before the age of 7, and 4 parents reported the first symptoms in their children at the age of 3. So I find it really hard to believe that such a young person can already be so impacted by culture to know what is polite or impolite, what is rude. So obviously I acknowledge the huge probably role of a cultural factor in misophonic reaction, but there must be something apart from that, like more biological factors. Most of the participants said that the first trigger was the close family member, but not all. Some people had other persons as the primary trigger. Some they didn't remember. That's why the numbers don't sum up to 100%. Here are some of the most common triggers that they named, but as you can see, they are not only misophonic triggers, because loud sounds or sudden sounds cannot be perceived as these are not very typical misophonic triggers, but we wanted to have a bigger picture of that. And then we saw that more than half our participants had family symptoms in their family. Symptoms in misophonia symptoms in their family, only 7% in siblings, but I think that's my opinion or hypothesis that only 7 because the siblings were often very young and maybe they haven't developed misophonia symptoms yet. I don't know, we need to check it in the future. Unfortunately, we didn't ask about misophonia in family in the control group, so we don't have the context, we cannot compare it. And then let's have a look at the age differences, because we divided misophonia group for younger children and teenagers, and we saw something very worrying actually. Here you can see that in the younger in a younger group, they displayed aggressive behaviors quite often, like shouting at the person making trigger or physical aggression towards people or objects, while that was very rare in teenagers. But when we look at the data, we see that most probably when they were growing up, they learned how to inhibit some behaviors, but still they had misophonia inside, and they had to cope inside. And almost half of them they self-harm during the exposure to the trigger sounds. And this is a very important message. Sometimes I remember I spoke to parents and they said, yes, my child, they had misophonia, but now they don't have it anymore. We can eat together and there is no problem. And then I talked to the child and they said, yes, we eat together because we have to eat together, but it's not true that I don't have misophonia. I feel it inside and I suffer inside. So please, as parents and as clinicians, remember that sometimes you may not see misophonia. That misophonia is sometimes, in case of teenagers and adults, invisible, but it's still there. And when we move back to two groups, misophonia and controls, I told you that I will share some unpublished data, but this is not peer reviewed, so be careful about it, be cautious with this. We assessed central auditory processing with several tests, like, for example, frequency pattern test. They were like, po, 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 like high, low, high, low, low, high. And the kids, they were supposed to say whether it was high or low, or there was, for example, gap detection threshold test. It was like shh, shh, and they were supposed to click as soon as they detected the gap. But we found no group differences, and we were not the first to show that there are no group differences in so-called central auditory processing. But there was a difference in another task, because there was also a visual task. The kids were supposed to click as soon as they detected the visual cue on the screen, and they were significantly faster than controls. Surprisingly, there were no differences in reaction time to auditory cues. I don't know why, but keep in mind that this is a very small sample, very preliminary data, no peer review. So yeah. And then we found no group differences between ADHD, dyslexia, and autism spectrum. But still, when we look closer, for example, to ADHD as diagnosed, as assessed by DSM-5 in misophonia group, they had, although there were no statistically significant difference, we see that there were slightly more cases of ADHD. So next time, when maybe we should use both interviews that we used here, interview and questionnaires, but also we should ask not only parents but also kids, because in that case we talked mostly to the parents. Sometimes kids were also, and teenagers were also involved, but not always. And what about symptoms of anxiety and depression? Here, the picture become clearer, but still a bit complex. When we look at the symptoms of anxiety as rated by parents, we see that in misophonia group, they had increased generalized anxiety disorder symptoms only. But when we look at the symptoms of anxiety rated by children, they had also increased social phobia symptoms, panic and agoraphobia, and GAD as well. And this can tell us at least two things. One, maybe parents are not always aware of the struggles of their children. This is one explanation, possible explanation. Another one is that if you look at the number of participants in misophonia group, they were rated by parents. They were 42 participants, while in child rated, there were only 33. This is because sometimes when the children were, I don't know, too tired to do test, or maybe when they were not able to read, parents did it for them. I mean, we used only parent-rated assessment. So in the parent-rated, the age was slightly lower. It could mean that at the beginning, when children with misophonia are young, they don't have any anxiety and depression, but then when they grow up, they develop it. This is why I think that it's really important to know it, to diagnose misophonia, to assess, to spot it, and to teach how to deal with it, how to cope with it. So maybe we can protect it, maybe we can prevent it. And the same case was in depression. When we looked at the parent-rated depression, there are no differences between groups, kids with misophonia and without any sound issue. But when we look at the child-rated symptoms, yes, children and adolescents with misophonia had significantly higher symptoms of depression. But please note, here we are speaking about symptoms. We are not speaking about disorders. We are speaking about symptoms of disorders. And then another other health issues. Uh, Not good news either. In misophonia group, they were significantly higher rate of migraines and strong headaches, psychosomatic complaints, also OCD. In case of tic disorder, there were no group differences, but we can see that they may be something. And I need to acknowledge that we assessed it very briefly. So next time we need to do that in very more meticulous way. And there were no differences in case of head injuries before misophonia onset and epilepsy and tinnitus. And then I told you, probably I told you, that we also asked mothers about the mental health, and unfortunately we found that postpartum depression was significantly more frequent in misophonia, in mothers of children with misophonia. So we should also focus on that group. There were no group differences in case of labor, natural versus C-section, birth complications, stress during pregnancy, prematurity of the child. And then again, there's some unpublished, very preliminary data. We found no group differences in case of the mother and the child relationship, neither in the mother-father parent relationship, partner relationship, and no group differences in parental stress. And while I am not surprised that there are no group differences in case of the mother-child relationship, I'm surprised that we didn't find parental stress significantly higher in misophonia group. But I don't know. As I told you, this is unpublished, no peer review, very 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 small sample. So we just need to study it in the future. And then the last thing, we found that misophonia in children was not linked to cognitive deficits, and we were not the first who saw that, and not the last who saw that. Children with misophonia actually were better in divided attention and in than their peers, and there were no group differences in case of memory, selective attention, overall school performance, intelligence, and even better inhibitory control actually increased the likelihood of having misophonia. And we checked it with a modified version of a Stroop test for children. Here on the screen, you can try yourself. You can name the colors instead of reading, like green, blue, red. So kids with misophonia were much better in this type of task, and also we were not the first who found that. Maybe this is because people with misophonia, they need to practice it since early childhood every day, inhibiting reactions to trigger sounds while studying, talking, and living in general. Now to sum up, mm, we know that misophonia is linked to increased anxiety and depression already since childhood. Maybe not since early childhood, but teenagehood, yes, unfortunately. And then I think we should talk to whole families, not only about misophonia symptoms in their kids, but also about parental stress, postpartum depression, as all we know probably that misophonia quite often, if not always, really impact the entire system, family system. It's not only the person who suffers from misophonia, but it's the whole family who sometimes need support. And then we know that misophonia may also be related to other health issues like migraines and headaches and psychosomatic complaints and others. And yet we were another group to show that probably there are no differences in terms of hearing and central auditory processing, but still we need more data. And we know that there are no, misophonia is not linked to cognitive deficits. Actually, probably, maybe it's linked to higher cognitive abilities. Yeah, but also we need more data. And as we currently have no cure for misophonia, I really think that the knowledge about clinical characteristics is important for psychoeducation. I would love my family to know about all these things when I was a kid, but that time misophonia, I mean, the term misophonia didn't exist, that nobody knew about it. So I really believe that with this knowledge and the knowledge that all we together gather, we can increase the quality of life of children and the families and adults as well too. Yeah, so thank you for the possibility to speak. Yeah, and by the way, maybe I will be looking for a postdoc soon. So if anybody knows something, you can let me know. Okay, thank you.
Thank you so much, Dr. Siepsiak. If anyone has any questions related to this specific presentation, please feel free to put them in the chat. The presentation was recorded from the beginning, so everyone will have access to the slides that were at the very beginning if you missed.
Yes.
Someone is asking, can you comment on the advanced cognitive skills aspect?
First of all, we certainly need more data. That was a very small sample. Actually, as I said, we were not the first who found it. Maybe because people with misophonia just exercise it every day. They need to focus on two tasks. That's why maybe it's better and inhibit reactions when they are talking or when they are learning things or studying or whatever they need to cope with the sounds. So maybe the cognitive skills gets better, but I don't know. And we are even not 100% sure that it's true. We need to repeat it. We need to repeat experiments to be more sure about it, because it was a pilot study.
What is recommended to help adolescents with misophonia?
Knowledge, I would say. We meet lots of adolescents with misophonia, and the most important thing for me is to meet parents, to talk to the parents, to provide as much knowledge as we can. Sometimes they parents and the adolescents they come and they hear that there is no cure. We can just support them with coping skills, with coping strategies, with some emotional regulation skills. But then they still hope, and this hope is so huge. And I think the higher hope we have, the more frustration we have. And also for me myself, the most important part of my misophonia and my patients and clients' misophonia is acceptance. To accept it and to learn to live with misophonia, because if we don't accept it, if we want to get rid of it, if we hate it and we want it every day, then it won't help.
Thank you. Do you have any research or learnings to share about kiddos with misophonia having particular gifting and physical coordination or musical abilities?
Um, no, I don't recall any type of such studies. I'm sorry. I don't think there is something like that. Maybe someone know and can share. Mm, sorry, I
We have, no, no worries. We have someone else asking, said, I was a bit confused about the part where you said you couldn't believe that children around 3 could be so advanced in noticing behavioral aspects. Does that mean that really young children, maybe under 6, don't develop misophonia so young?
I mean, I meant that because there are some theories that misophonia is due to cultural aspects, like I hate eating because this is impolite, this is rude, they should not eat, and this is why I have misophonia. But I would say that this is not true. Misophonia is a reaction to repetitive soft sounds, not eating sounds, any type of sounds, but because we are exposed to eating or breathing sounds quite often. Maybe this is why these sounds are the most triggering. I don't know. We need to have a look at it. But when I said that, I can't believe that 3 years old could be so impacted by cultural factors. I meant that I don't believe that 3 years old already know what is polite and impolite so much. Or maybe they heard from parents, but they are not as impacted as we adults. I don't know if you understand my English. Uh,
Thank you. I'll look for.
but yeah, definitely we can see misophonia in very young kids. We see them in research and clinical practice as well.
We have another question. Does DBT help with misophonia?
I mean, yes, certainly DBT provides lots of coping strategies, so we include it. We include it in our therapy sessions, definitely. Yeah.
And how do you differentiate misophonia from conditions like autism spectrum disorder, ADHD, or OCD, specifically in younger patients?
Um, well, with the criteria, uh, most of people, as most of the studies show, most of people with misophonia don't have ADHD, neither autism spectrum disorder. In autism spectrum disorder, also like the core is social functioning. In misophonia, the core of the disorder is reacting with strong aversion to sounds, to repetitive triggers, and people with misophonia have struggle with society, with social interactions as a consequence of misophonia. So this is one of the things that I would differentiate it. Um, uh, I'm not sure.
We've got about 4 minutes left for Q&A. If anybody has any more questions, we'd be happy to ask them. I'm curious, Marta, what is your next ideal study? If you could do any study about misophonia in the future, what would you choose to research?
Oh, so we already applied for two grants and we are waiting. One is longitudinal study. I hope we will be studying kids and their siblings. So one would have misophonia and another one would not have misophonia yet. And we would like to look at them through time, like each half a year, through 2 or 3 years, and also look at the how parent-child relationship can impact, or how maybe it could be seen as a protective factor. So this is one, this longitudinal study, and then another study, like more with EEG assessment. We want to verify whether misophonia is not only auditory disorder, but cross-modal disorder. I believe it's not only about auditory. I think the same type of sensitivity we can observe in people with misophonia, like visual. Oh, sorry. Uh,
Marta,
sensitive
I
over responsibility and tactile over responsibility. Sorry, I got so stressed.
this is okay. I have a question for you that's based on I'm scanning through a lot of it's a very active chat. I'm trying to keep up and I'm scanning through it, and there's a whole lot of questions about exposure therapy, habituation-based exposure therapy, ERP, and people are commenting, and there's a nice consistent response from a number of clinicians who have a lot of expertise with misophonia, indicating that exposure with response prevention for misophonia is counterindicated and may make things worse. I just wonder if you could comment from your perspective on that. Do you agree with that? And what are your thoughts about exposure therapy for misophonia?
I mean, we use kind of modern exposure only if a person is ready. In kids and adolescents, not as often as with adults, but it's not based on habituation. It's more like inhibitory learning based, not habituation. So we try to like play with sounds, make fun with sounds, pretend that the sound is made by an animal or a happy panda. We just try to make fun with sounds. I know it may sound ridiculous, so we never do that at the first session. We need to approach sounds from a different perspective to make new associations. Yeah.
And you're
But
differentiating that from habituation-based traditional exposure therapy, correct?
I do, yes.
Yes.
It's yes, I
Yeah, yeah.
definitely.
Yeah.
Yes. Yeah, we should remember that the person should accept it. If the person, if severity of misophonia is extremely high, we even recommend headphones, avoidance, but it should be smart avoidance, because we know that in anxiety disorders, we rather don't recommend avoidance because this is reinforcing the symptoms. But in case of misophonia, this is completely different because sometimes we need to learn how to deal with avoidance. So it's smart avoidance, not harmful avoidance. But me myself, I can't imagine myself to get in a plane without headphones. That would be ridiculous. Why to expose yourself to this type of triggers? You are not going to habituate to this, so why?
Right. So just to clarify, since the questions are still coming here, I'm seeing we don't recommend traditional habituation-based exposure, traditional, what most people call exposure therapy. We don't recommend that. That is not recommended as a first-line treatment. There's studies that look at the feasibility of that, and patients find that to be the least effective, the least acceptable treatment for them. In my own clinic, we've never found patients who've wanted that. We've almost always found patients who, when they come in, are afraid we're going to do that and don't want that, and we don't do that. But the point is, this is not, just to be clear to everybody, there's not a recommendation for traditional exposure therapy. But what Marta said is true. There is a recommendation to use sounds and do work with sounds to recontextualize sounds is different than traditional exposure therapy, and it's something to talk more about when we have more time.
Yep.
Yeah. Yeah, I think we should stress that we will always deal with the sounds. I mean, you will have an exposure in the daily life, so it's better to learn how to deal with it, to learn how can you cope with it in the office during the sessions, because later it can be too late. Yeah.
I think we're at time for this session if you want to move